Our next topic is pain is inevitable but suffering is optional. Practicing regional anesthesia in small district hospital, the challenges. The speaker is Dr. Surajit Giri.
Yeah. Very good morning to all of you. So we are meeting again after 4 years. 2 years, no? 2014 to 16. So that was in New Delhi. Now in Ahmedabad. And how the Gujus are welcoming you all, I came to know yesterday night. They are ready with some dinner, small amount, whatever it is, but they are ready, and they have welcomed us with great pleasure and honor. So I am here to discuss a pertinent question that always asked by our fellow colleagues: how to establish regional anesthesia technique in small center. Now, sir has already told, so what to do and what not to do and how to control the acute pain. Now, it is my turn how to establish this regional anesthesia technique in small center, especially in a district hospital. So, greetings from my small town Sibsagar, which is around 400 kilometers east of Guwahati, and this is a very small town. This is a small district hospital. And my town is very much famous for historic monuments of Ahom king. This Assam was ruled by Ahom's king, and my place was once it was the capital of Ahom king. So greetings to all. So this is my declaration. I do not have any conflict of interest. I have taken written consent of the patient as well as from my parents of the kids, and I have taken some photograph and cartoon from our fellow colleague Ganesh Chaudhary. Thanks to him. So even in simple injection to surgery, there is pain. This is inevitable. There will be pain. Whether surgery is doing in Liverpool, UK, London, USA, or in Sibsagar, that is in the Royal Hospital, there will be pain. That is universal. That is the point. But thing is that the suffering due to pain is optional, totally optional. It depends upon you. That is the anesthetist, and the anesthetist. So whether you like to see this type of patient in immediate post-operative period, this is amazing. It is incredible to see this type of patient in post-operative period. It will be fascinating to you. The anesthetist, not only to the patient, not only to the surgeon, but to the anesthetist. And he will be so much of happy to witness this type of patient in post-operative period. Whether you want to see this type of patient in post-operative period, these are the elderly group. They are the senior citizen. They have already given lot of to our society, and it is our turn to give and control their pain. And we are doing it from last few years. In the pre-operative period, we had on-arrival block to intraoperative period, and extending the block to post-operative period with multimodal analgesic technique, already Sal has described. Now, two things is important in this elderly group. You have to control the pain because these people have lot of comorbidities. If the pain gets upper hand, then these comorbidities get upper hand, and there will be morbidity and sometimes mortality. You have to curtail the pain. Anyhow. Second important thing, if this patient had pain in post-operative pain, they suffer pain, then they will go into a delirious state. Now, elderly patient, if they goes into delirium in post-operative period, mind it, it is very, very difficult. You give those, and consult even the psychiatrist also, they will not get benefit. The important thing is that you have to control the acute post-operative pain, and we are doing it from pre-operative, intraoperative to post-operative period. Now, if you see this type of kid in intraoperative period, it will be again a fascinating to you, to your staff, to your surgeon, and even to the parents. What I do, whenever the surgery is going on, I take picture, sometimes video, and I give this picture and video to the attendant. There is a lot of sharing thing. Gender is there, Bluetooth is there, whatever it is. Then it will give an publicity to the society. Okay, now whatever I give them the pictures or video to them, they see this the surgery is going like this, your kid is very much happy, he is sleeping and he is not feeling any pain. Now this is again propagating your anesthesia and anesthesia practices in the society. And this is blockbuster in my center. So what do? We give nerve blocks in front of parents in OT. What do? We apply some pre-lock cream 1.5 hours before and give the block in front of the parents. And I ask them to take the picture, what I am giving. And that will again gives an publicity to your anesthesia and anesthesia practices, what you are doing. You have to market yourself, otherwise you are not going to sustain in a small center. Now this we are doing from last 10 years, okay, irrespective of the age, kids, neonate or the elderlies. And we are doing from thorax to the lower limbs. We are giving regional anesthesia technique, we are giving multimodal analgesic technique to the patient and absolutely controlling the pain, intra-op and post-operative period. That is what we are doing from last few years. Now to get this point, to get to this level, it is very difficult for me. Let's back to 2006 when I have just passed out my anesthesia residency in Assam Medical College, Dibrugarh, and I came back to my place, that is Sibsagar, and you will like to know my position. What was the position? This is me. This is tiny kid, and this is surrounded by a lot of problem from the surgeon, problem from the staff, problem from the instrument, problem, and nobody knows about the peripheral nerve blocks. Nobody have peripheral nerve stimulator, etc. and all. Now when I came this idea, what is my position? Let's see. See, I came with an idea. I was pushed back by a lot of problem, different problem that I am going to discuss. And sometimes I was teased by these all problems, and sometimes I get frustrated because some problems I could not solve. I could not change them at all. I was again pushed back, and now I am teased. What Giri is doing, that is bullshit. So peripheral nerve blocks does not work. Here it has a lot of problems. It causes complication, etc. and etc. at that time. See, teased like that. I was laughed, and sometimes I was tossed in the air. See, I will be tossed. So this is my position in 2006. This is none other than me. So I have to, yeah, thank you. Now I have to change the scenario in my center. Now this I always believe, when you focus on problems, you'll get problems, and there is a cascade of problems. अरे problem हो जाएगा, इसमें नहीं है, problem हो जाएगा. So there is a cascade of problem. But when you will get some focus on some possibilities, you will get more opportunities. You will see opportunities. What I always believe in this point, and I am going to prove that. Now I am going to describe 15 numbers of approach. If someone follow this approach, I am sure he is going to implement regional anesthesia technique in their center. Forget about what it may be in Moon, or it may be in Sibsagar, or it may be in any rural hospital. The first and foremost is that you have to assess the local area. What type of surgery is going in? What is the practice pattern? And what the community feel about it? When I came and I discussed with the patient, and they said, anesthesia? What is it? What is anesthesia? Behoshi. So they have no idea about anesthesia, what the anesthetists do, what they can do, and what actually they are doing. They have no idea at all. Now assess the surgical procedures in the local area. If you train yourself on cardiac surgery, thoracic surgery, and want to practice in Sibsagar, you will be going to fail. Because in the rural area or that area, what type of surgery is going in, you have to find out, and you have to update or educate yourself. At the time, in 2006, the surgery going on was abdominal surgery in terms of LSCS, hernias, gallbladder, appendix, followed by INT and ortho. Few numbers of cases of ortho, but later on in 2016 it was shifted to ortho, abdominal, and then INTs. Now in that time, in 2006, the anesthesia practice was tube in, tube out, tube in, tube out, and few numbers of the spinal anesthesia. Now I have witnessed the people in the post-operative period, they are screaming in pain. They are asking for pain, 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 and people are giving diclofenac, this 14, phenergan, etc., etc. But I am not at all satisfied with post-operative pain. Even my mother had this appendicectomy in the 90s, and she was not controlled the acute post-surgical pain. Now she has frustrating pain in the appendix area because it developed into chronic pain. So that's I want to know, and I want to know how the people in the world or in India is practicing this post-operative period, and how they are controlling the pain in immediate post-operative period. And that's why I went to Coimbatore Ganga Hospital, and I have spent almost around 1 to 2 months with Bala Bhanket sir to know how to tackle the post-operative pain, how to what is the role of regional anesthesia technique in decreasing the post-operative pain. Because knowledge is power. If you have knowledge, you will be power. Let's see. This is a beautiful lady. She is pulling, 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 and pulling, but she will not able to open the door. The knowledge is that you have to push the door, and if you have knowledge, the things will be easier. So that's why it is called knowledge is power. If you want to implement one program in your center, you have the knowledge. You have to know in depth what you are going to do and how you are going to deliver, and you have to get the updated knowledge. Now I came back to Shivsagar after my training. Then I found there is a lot of problem. There is no staff. Now the staff people are like that. If there is a OT, they go to the operation theater, they assist, and whenever there is no OT, they go to the casualty and do the other duties. Means there is no permanent staff. If you do not have permanent staff, it is very much difficult to organize a unit or implement a protocol. I have written to superintendent. I have done a small meetings with my staff, with her sister staff, and I have written. Almost I have to give 15 numbers of letter, and ultimately they have given some technician. That is one number of technician and 2 numbers of staff to start my program in my center. So it is my turn to educate and appreciate them. I have educated them about all techniques, what is regional anesthesia technique, how to give this anesthesia, what is the role of monitorings, etc. I have educated extensively to them, and what is the role of investigation, what is the role of consent, etc. and etc. And sometimes if they do work, better work, always appreciate them. Do not scold them always, because, and also that also teach them how to work in a team, because if you work in a team, then even in the adverse situation, you will be in success. Then next important thing, you have to change your attitudes. That is important. Now these animals follow the protocols or guidelines. Even the lions follow the protocols and guidelines. The technician and your staff will follow the protocols and guidelines. Your surgeons will follow the protocols and guidelines. The thing is that you are the leader. You are the leader of the OT. You have to change yourself. You have to tell them that this is the way to enter the OT. These are the do's and these are the do not in OTs. These are the do's and do not for sterilization, etc. and etc. But if you give lectures and if you do not follow, nobody is going to follow you. So first and foremost, before starting the program, you should change your attitudes. Now, this is the important thing. You have to start the program, and you have no money. At the time, I'm getting salary of around 20 to 25,000, and the price of the PNS machine was 40 to 45,000. The people like me, for newbies, you have seen my position. There is a tiny kid, so it is very difficult to purchase a 40 to 45,000 machine. I have asked my surgeon, I have requested my hospital, but they told, oh, this is a new project. I'm not interested. May get fail. So nobody is interested to invest money at that time. So what I believe that there is a possibilities in problems, and I found the possibilities in the problem is that I have asked the B1 people whether they can give this machine in a EMI basis, or the B1 people told me, oh, there is maybe an option. So they have talked to their seniors, and ultimately I purchased the machine in EMI basis, and they took this idea from me, and they have almost sold 100 plus PNS machine all over India in EMI basis. This idea was given by me. Commission, no commission, no commission. They acknowledgement no commission. So that is the thing. So if you have problems, there will always possibilities, and you will get the possibilities. So that's created in mind, and I purchased the machine in EMI basis. Now next, if you solve one problem, there will be another problem. So problem is cost of the stimulation needle. They will say, oh no, Dr. Giri, do not start this program. The cost of the stimulation needle is 900 rupees. My patient will not. Most of the patient is very much poor. They cannot afford it. Now it is like this. The people, our general people, they goes to the restaurant, they goes to the multiplex, they spend a lot of money, 1,000, 2,000, 5,000, everything, they do marketing. But whenever there is a health issues, मेरे पास तो पैसा नहीं है यार, मेरे पास पैसा नहीं है, वो डॉक्टर साहब तो बहुत ज़्यादा ले रहा है, वो जो लुटेरा है. The same thing applies to the anesthetists. They are applying all of this cost, they are applying this using laparoscopic instrument, etc. उसके पास cost का कोई problem नहीं है. जब भी anesthesia का बात आएगा, there is a cost का problem है. There is a cost problem. So they have, again I have solution. What I have did, I purchased the stimuloplex needle in a wholesale basis. That time it was around 900 rupees. I purchased it around 600 rupees, and I shared the cost with the patient by autoclaving and reusing the needle till 2013. From 2013, I am not doing that because it is already established technique in my center. So it has the cost of the needle has been solved. So I have started my practice with an stimuloplex needle, the machine, the marker, and a measuring tape. That is must for any peripheral nerve block technique. Now the biggest hurdle is the surgeon. You have to solve them. Now they have a lot of misconception. They says, oh, you are going to start a program, but please do not do that, because I have seen a lot of complication. I have seen you people do multiple puncture, talk, and they says you people give most of the time general anesthesia. I have seen 90 to 100% failure. I have seen complication, blah, and please do not start. I was stunned because I have machine, I have purchased my stimuloplex needle, and now surgeon says do not start the program in his patient. So what to do? So I have asked him, I have requested him, talked to him, I told him that I am trained myself, I have instrument, I have drugs, just give me 40 days. In these 40 days, if I fail, and if you get this type of problem, if the patient says dissatisfaction to our anesthetic technique, then I will forget about block technique in my life. That I have given them the assurance and told them just give me 40 days. So this 40 days period was my trial period in 2006. So next important is you have to market. This is a new technique in your center. One of the new technique, and people doesn't know about your technique. So what I have done is that the surgeon, general surgeon, they comes with a lipoma, they comes with a ganglion, they comes with an abscess. They do most of the surgery under infiltration anesthesia, isn't it? So what I have told them, so just give me those patients. I'm going to give the block, and you'll do the surgery. And I will not charge anything. Patient will not be charged anything. Means I am giving them the free service up to 1.5 years. And this practice, that's why I'm practicing my regional anesthesia technique. So I have to, because you have to market yourself, and that will cause us marketing to the surgeon, marketing to the patient. So it is like Reliance 4G. They are giving up to 3 months, everything free. Chalao. Now we are used to 4G. Oh, no, we are not going to. That is the same issue. So I have marketed myself. This is essential in your initial practice. So your surgeon are convinced, you have marketed well. Now you have to prepare the patient. So you have to do PSC. You have to communicate to him. You have to explain them, and most importantly, assure them. Assure them that you are not going to give multiple pricks. You are not. The patient will not be operated in pain. The assurance should be bold, and it should be confident at initial period of practice. Now your patient is prepared. Your surgeon is prepared for regional anesthesia technique. Now it is your turn to give successful regional anesthesia technique. Now have you noticed me today? Standing there. So what is that? So it is like that. You have to give block well ahead your surgical time. So I have waited here till surgery finish to my turn. Same thing applies to your block techniques or your anesthetic technique. You have to be ready at least well before surgery. If the surgery is 7 p.m., give block at around 5:30 p.m. Then you give enough time to LA to work, around 1.5 hours. No, but doesn't worry. The block will not wear off if you have given properly. Then you have to assess the block, whether my block is working or not. That is the assessment of the block. Then if it is not working, then supplement the block. And if supplementation is not possible, then what will do? Go for fentanyl, propofol, ketamine, midazolam? No, I'll let you know. But always use your brain. If the patient says, "Arey, mera to hath pura sun ho gaya, utha bhi nahi sak raha hai, so it is not possible to move his limb," you feel, "Oh, my block is working. Now it is ready to go for surgery." No, ladies and gentlemen, still your patient is not ready for surgery. You have to use your brain. You have to use your science. The science is that you have to assess your block. Look for 4 P's for upper limb. Push for the radial, pull for the musculocutaneous, pinch for ulnar area, and pinch for the median area. If these 4 P's are gone, means osteotomy and myotomy are blocked. Same thing applies to lower limb. Push for the tibial, pull for the obturator, pinch for the lateral femoral cutaneous nerve, and punt, that is kick in air. That is called punt, means for femoral. If it is gone, 4 P's are gone, means myotomy is blocked, osteotomy is blocked. But ladies and gentlemen, still your patient is not ready for surgery. Because for complete anesthesia and analgesia, you need to block myotomy, osteotomy, and dermatomy. You take an ice cube, run over the incision area. If the patient is getting temperature sensation or cold sensation, means dermatomy is not blocked. So ask the surgeon to infiltrate the incision area, or if there is a chances of supplementary block or auxiliary block or auxiliary block, then supplement accordingly. So you have to remember, you have to block osteotomy, dermatomy, and myotomy for complete anesthesia and analgesia.
Last 5 minutes.
Oh, sorry. Now, suppose you have pain during operation, what will do? Now, explain to the patient and surgeon. If you tell, "Oh, this is not a candidate for block, I should not give regional anesthesia technique or peripheral nerve block to this patient," that will not give the answer. Surgeons are not full. Patients are also not full. You have to assess. Sometimes the patient complains the pressure sensation and touch sensation as a pain. You just give midazolam or fentanyl, that will be sufficient. If the patient is complaining of pain, if there is a chances of rescue block, you give the block. But if there is a patient still complaining of pain, you have to accept and you have to convert into general anesthesia or other technique, because it may happen to anybody in anywhere. Now your hands free, you are giving blocks are working fine, your hands free. It doesn't mean that you entertain the surgeon with your phone calls or adjust the light. It is not your duty, mind it. It is not your duty. There are other stuff they are going to do it. It will decreases your dignity. So at the end, you have to you require a safe patient and safe RA, and these all applicable to the patient. And if possible, always inject yourself. Backup should be always ready, including lipid in your cart. And RA techniques should be same to all patients. There should not be any bias like this. There should not be any bias. Okay? And now ask yourself how much you are trained, skilled, because this guy, he's trained and skilled. He will learn safely, but not me. So you have to ask yourself, if I give this block, whether there is a complication, then how do I manage it? Whether I am skilled enough to give that block. So you have to ask yourself and avoid nerve blocks for overloaded routine, because it needs time to block the nerves. Now, how to tackle the different types of surgeons? I remember a surgeon in 2007 when I have replaced the Quincke needle with a Whittaker needle. And he told me, Dr. Giri, do not use Whittaker needle. This is too costly to my patient and he is very much poor. Okay, no problem. I have written down. Dr. X told me to use this Quincke needle in case seat. Now, fortunately to us, I am telling you, fortunately to us, but unfortunately to the patient, she developed headache in 5th postoperative day. And she told me, doctor, why it happened to me? There was 6 cesarean section. Nobody had headache, but only me had headache. What has happened to me? I showed them the document. Your surgeon told like this, not to use the modern anesthetic technique. So she was so much of furious with the surgeon. And next time when she came for cesarean section, when she came to cesarean section, she changed the surgeon, not me. I was the anesthetist, but it changed the surgeon. So what do you need? You have to bypass the surgeon. You have to get direct contact with the patient, document in and show them. Only mere documentation is not sufficient. You have to communicate with them that the surgeon is telling like this. This is the previous anesthetist, yesterday's anesthetist. But now anesthetists are trained, skilled, and they can respond. Thank you very much. The important thing is that you have to empower the public. If you empower the public, you will get freedom from surgeon's dictation. That what we are doing from last few years. Even you do a lot of things to the society, you will be criticized heavily, because people like this are always ready. They are always ready. They are opening eyes. And if I get complication in my early days, if there is a side effect, I will be nowhere. I will not be here now. I will be somewhere else. But by the grace of the God, everything going fine. Now our society is very much unique. They will not help you. Whenever I go to when I ask to the help, nobody is come forward to help us. But when you perform, then the society comes to help. Same thing happens to me. This is like ABCD now. Now what is they have purchased one more PNS for me. They are ready to buy ultrasound and workstation, but we are stuck somewhere around PNDT Act. I'm not concerned about the cost factor now, but you love to hear, people love to hear, is that I fix my salaries, decide fees according to my choice. Now this is not a fast forward. It is not a fast forward topic. It is not a magic, because she took almost 12 years. I took almost 10 years. Someone may took 15 years, but you have to stick in your protocols and guidelines. Stop blaming Indian Society of Anesthesiology. Stop blaming your society. Stop blaming your politician, because you have to work yourself. You have to create a balance between the surgeons, societies, yourself, and your branch. Because you have to do yourself. This is the nice picture that is from the last flood in our Assam. See what they are doing. There is a thin line of survivability, and they have utilized. They have opened their brain. They have opened their ears. So that you have to do in a small center. So ladies and gentlemen, if you do these things, if you can handle the criticism and everything all, if you can handle the surgeon, if you educate your societies, then you will be a leader. And leader is not about the size, it is about the knowledge and the wisdom. See, the size is same. In the first video, my size is same, and the last video, that is this slide, my size is same, but I have increased my knowledge, I have increased my performance, I have acquired my skills so that I can lead my societies, I can lead my anesthetists, I can lead my surgeons and my patients and family members. So ladies and gentlemen, pain is always inevitable. It depends upon you. You are the only factor. The pain is optional in your center. You are never late. You can start anytime, anywhere. You are not late. And the biggest reward for me, the biggest reward for me is she wants to be a block anesthetist. She is so much of fascinated. She is so much of interested to my works, and whenever he asks me, Papa, what you do actually? So I tell him, I give injection like this, and I decrease the pain. Oh, you are decreasing pain. You are doing so much of working for the patient and your the small kids. So she is very much convinced by my work. So this is my biggest reward. Nothing can be replaced by this. So, thank you very much.
Thank you, Dr. Surajit.
Very excellent presentation as usual. I think what stands, we can see a future CM of maybe Assam. Yeah.
I mean, that was an excellent presentation, and I'm sure a lot of people would have got encouraged by what Surajit has done. But like I said, it's not something which can be done by a magic wand. It doesn't happen in days. It doesn't happen in minutes. Okay, it takes time and perseverance. The next speaker was supposed to be Piyush, and unfortunately he's not here today because his mother is not well. He had to actually travel in emergency to Bhubaneswar, where his mother is. Actually, I do not know. Yes. You okay, Surajit? Okay.